Hello and welcome to this lecture. Today we are going to discuss about the basic pharmacology of the anti-arrhythmial agents, and the main function or main responsibility of these drugs is to reduce the ectopic pacemaker activity and modify conduction or refractory period in re-entry circuits to disable circus movement. So when we talk about these therapies, the main important thing is that the problem what will happen in cardiac arrhythmia, that there will be, you can say that, electronic firing, or you can say that there is an increase of the activity around SA node. As we know that SA node and AV node, they work together with Bertram G fibers to produce the normal rhythm of the heart. But what happened that when there will be ectopic pacemaker activity, or you can say abnormal heart rhythm, because of the ectopic activity around the atria or around the ventricles, or electronic firing, or you can say that the increase of the neuronal firing, that increase the electrical conductivity, and that is responsible for abnormal heart rhythm.
Antiarrhythmic agents are drugs used to suppress abnormal rhythms of the heart. They act to either interfere with the dynamics of cardiac action potentials by blocking a certain ion channel, or block the sympathetic effects of the autonomic nervous system on the heart to slow down heart rate. There are 5 classes of antiarrhythmic drugs. Class 1, sodium channel blockers. These drugs bind to and block the fast sodium channels that are responsible for the depolarizing phase in contractile myocytes. The result is a slower depolarization with a smaller amplitude. Slower influx of sodium results in a smaller flow of positive ions through gap junctions to adjacent cells. The adjacent cells take longer to reach the threshold required to generate a new action potential, ultimately resulting in a slower propagation of action potentials through the myocardium. This reduced conduction velocity helps to suppress formation of reentrant circuits, hence the use of these drugs for treating reentrant tachycardias. Class 1 agents are divided further into subclass 1A, 1B, and 1C. These subclasses differ in the strength of sodium channel blockage and in their effect on the duration of action potentials and the effective refractory period, the ERP. While subclass 1C has no effect on ERP, 1A prolongs and 1B shortens ERP, respectively. Changes in ERP may have different outcomes for different types of arrhythmias. A longer ERP generally reduces cardiac excitability, but prolonged repolarizations may increase the risk of torsade de pointe, a type of tachycardia caused by after depolarizations. Class 2. Beta blockers. These drugs bind to beta-1 adrenergic receptors and block the sympathetic influences that act through these receptors. Sympathetic nerves release catecholamines, which act to increase SA node firing rate and cardiac conductibility, especially at the AV node. These activities may precipitate arrhythmias. Beta blockers suppress sympathetic effects, thereby decreasing heart rate and slowing down conduction through the AV node. The latter is particularly useful in treatment of tachycardias that originate upstream of the AV node, known as supraventricular tachycardias, or SVT. Note should be taken, however, that beta blocker treatment may cause AV blocks. Class 3. Potassium channel blockers. These agents block the potassium channels responsible for the repolarizing phase. The result is a slowed repolarization, hence a prolonged duration of action potentials and refractory period. This reduces the heart's excitability and suppresses reentrant tachycardias. However, these drugs may also cause arrhythmias because slow repolarizations are associated with longer QT intervals and increased risk of torsade de pointe. Class 4. Calcium channel blockers. These drugs block calcium channels that are responsible for depolarization in SA and AV nodal cells. Blocking these channels results in a lower sinus rate and slower conduction through the AV node. However, because calcium is also involved in cardiac myocyte contraction, these agents also reduce contractility of the heart and should not be used in case of systolic heart failures. Class 5 includes all drugs that act by other or unknown mechanisms.
So what these drugs are doing, they are responsible for reducing the ectopic pacemaker activity and modification or modifying conduction or refractory period so that we able to reduce the neuronal firing. And when we talk about the treatments, there are 4 major treatments. We can give sodium channel blockers. We can block the sympathetic autonomous effect in the heart. We can prolong the effective refractory period, or we can give calcium channel blockers. So these are the 4 pharmacological activities that could be given under these circumstances. When we talk about channel blocking agents, these channel blocking agents, as we discussed in our previous slides and previous lecture, that there is a strong role of ions such as sodium ions, potassium ions, calcium ions. And what actually these channels are doing, that we're trying to bind the drugs will bind either on phase 0 or on phase 2. Phase 0 is the time where the channel will be activated, whereas phase 2 is a time where there will be inactivation of the channel. So by binding with these channels on different phases, we block the electrical activity, or these channels, the drug will work when there will be high tachycardia, fast tachycardia, significant loss of the resting potential is responsible for electrical activity, increase of the electrical activity. So what these drugs are doing, that in these cases when there will be fast tachycardia or significant loss of the resting potential, the drugs will bind with these channels either on phase 0 or on phase 2, and then they block the electrical activity which is responsible for abnormal heart rate or heart rhythm. When we talk about the cycle of these drugs, you see that if I move to the point 1, that cell with abnormal atomicity, the drugs reduce phase 4 slope, then they are responsible for blocking either sodium channels or calcium channel and reducing the ratio of sodium or calcium permeability to potassium permeability, and that is why then it responsible for re-entry arrhythmias. And antiarrhythmic drugs slow down the conduction by one or both mechanisms. How they work? Number 1, they mention about the reduction of the available unblocked channels and reduce the excitatory current to a level below the required for propagation. Or number 2 is a prolongation of the recovery time of channel or effective refractory period enhancement or increase. And when we discuss this point, the main thing is important that they are responsible for reducing the ratio of sodium or calcium compared to the potassium permeability. So what these drugs are doing, they are responsible for increasing the potassium level and reducing the sodium level, and that is one of the way that these drugs are responsible for slowing the conduction. And how they slow the conduction? By already available some unblocked channels. If the channels are unblocked, we try to reduce these unblocked channels, because if there are more unblocked channels, then it will more bind to the sodium and then it can increase the excitability. So by reducing the availability of these channels, especially unblocked channels, we can reduce the excitatory level that is responsible. Or the second thing is that we can prolong the effective refractory period. So by prolonging the effective refractory period, it can also help in reducing cardiac arrhythmias. So antiarrhythmic drugs can suppress the ectopic atomicity and abnormal conduction, especially in depolarized cells, and then it is responsible for minimizing the effectiveness of the electrical activity in normal polarized part of the heart. So actually when we talk about this slide, the main important thing is that the cells they are responsible for reducing the abnormal atomicity, especially phase 4. So that at phase 4 they block the channels like sodium or calcium channel, so that there will be the less sodium compared to potassium level, and they are responsible for reducing the excitatory level, and that is required for propagation. So that is very important, or they can increase the refractory period. Obviously if there is less sodium, then the less sodium and more potassium can increase the refractory period, especially at phase 2, and that from that then it can helps in treating the abnormal atomicity or atopic atomicity or abnormal conduction, especially in depolarized cells. So when we talk about sodium channel blocking agents, because I already discussed that the sodium has an important role in excitation. So what we need to do, that we need to give some drug that is responsible to reduce that excitation by blocking the sodium drugs. So we have in different classification of drugs, like 1A, which consists of procainamide, quinidine, diosparamide. When we talk about procainamide, the effect is they are responsible for slowing the conduction velocity and pacemaker rate, and prolong the action potential duration and dissociation from one sodium channel with intermediate kinetics, and they are having direct depressant effect on the sinoarterial node and arterioventricular nodes. But their excess use can be responsible for excessive action potential prolongation, and obviously prolongation could be extended, it could lead to QT interval prolongation, and excessive use can be responsible for excessive slow conduction, and it can induce Torsades de points arrhythmia, or it can be responsible for syncopes, or long-term therapy produce reversible lupus related symptoms. Then we have quinidine, and the cardiac effect is actually they slow the upstroke of action potential. As we know, from level 2 to level 1, there will be sudden shoot of the peak. So what these drugs are doing, they are responsible to slow the upstroke of the action potential and responsible for slowing the conduction. But obviously when the conduction will be slow, then it could lead to prolongation of the QRS duration of the ECG by blocking the sodium channels, and they can prolong the action potential duration by blockage also the potassium channels. So their effect on the toxic effect on the cardiac, like excessive QT interval prolongation and induction of Torsades de point arrhythmia, and they having some extra cardiac effect like GIT effect, like diarrhea, nausea, vomiting. It could lead to headache, dizziness, and tinnitus. The pharmacokinetic or therapeutic use is they are readily absorbed in the GIT and can be eliminated through hepatic metabolism. When we talk about class B drugs, 1B, examples are lidocaine or mexiletine. So when we talk about lidocaine, they are also responsible for blocking activated or inactivated sodium channels with rapid kinetics. Their half-life is 1 to 2 hours, so it means that they are very fast acting kinetics, they work very fast. The loading dose is about 150 to 200 milligram administered over about 15 minutes, but they are having a lot of toxic effect like paresthesia, tremor, nausea of the central origin, lightheadedness, hearing disturbance, slurred speech, or convulsions. When we talk about class 1C drugs, the drugs is actually we have flecainamide, propafenone, or we have moxicillin. And when we take one example like flecainamide, they are also responsible for blocking sodium and potassium channel with slow unblocking kinetics. So what they are doing, that they are blocking these channels like sodium and potassium, but with slow unblocking kinetics. So the unblocking will be little bit slow down, as they are blocking agent, but their blockage is slow, mean they block the channels and then slowly unblock the channels. That is very important, because obviously we cannot permanently block these channels, because if it could done, it could prolong the QT intervals. So they are potent blockers, but they having with slow unblocking kinetics. So the blocking and unblocking is very important. They are not completely blocking, and they are not prolonging the blocking, they are unblocking, but with slow blocking kinetics, used by patient with supraventricular arrhythmia, the arrhythmia that could be arise from the ventricular ectopic, and can cause severe exacerbation of the arrhythmias if patient having previous myocardial infarction or ventricular ectopy or ventricular tachyarrhythmias. They are well absorbed and their half-life is approximately 20 hours, and they are eliminated by hepatic metabolism and through kidney. Then we have beta adrenoreceptors blocking drugs which belong to class 2. The examples are propranolol. So what the mechanism action, that they are responsible for beta adrenoreceptor blockage. So what they affect directly on the membrane, especially sodium channel blocker, and prolong the action duration, slow down the sinoatrial node atomicity and AV nodal conduction velocity. The clinical application, they are used for arterial arrhythmias and prevention of recurrent infarctions and sudden death. The pharmacokinetics parameter are, they are orally absorbed with parenteral duration of 4.4 to 6 hours. Toxicity consists of asthmas, AV blockage, acute heart failure, or interaction. It could be interact with cardiac depressants or drugs which are that can cause hypotension. Then we have the drug that is responsible for prolongation of the effective refractory period by prolongation of the action potential. We already discussed that there are two ways that we can handle different kind of arrhythmias. Either number one, we blocking the sodium channels, or we can prolong the refractory period. So these drugs are also responsible for prolongation of the refractory period by prolongation of the action potential. They are also known as class 3 drugs. So when we talk about these class 3 drugs, they are also known as potassium channel blockers. So they block the potassium channel and resulting in slow repolarization phase, and prolong the action potential and prolong the refractory period, because we know that potassium increase with time. So what these drugs are doing, that they blocking the potassium so that it slow down the action potential and prolong the refractory period. So they are responsible for reducing heart excitability and suppress the re-entering tachycardia. So if you take a look of this picture, we already mentioned that Z from this phase, from this is the Z naught, or let me show you this picture. Like if you can see, this is the phase 1, 0 phase, and this is the upshoot level, and you can see that in that case there will be sudden increase of the sodium, they will be increased. So what class 1 drugs are doing, they are blocking the sodium channels. So that's, they could be 1A, 1B or 1C, moderate, weak or strong, and they are all actually controlling the sodium blockage, that how much we need to block the sodium. That is very important. They all are responsible, 1A, 1B, 1C, they are all responsible to block them, but at which extent they block, it varies. That's why I classify at moderate, weak or strong. 1C is more stronger. When we talk about class 3 that we are now discussing, these are potassium channel blocker, and we know this phase 2 to phase 3 is very important, especially in phase 3 when the potassium is going out. We have to see this level, that at that stage they are responsible for slowing down the refractory period, and these channels with class 3 drugs, they are responsible for blocking the potassium channels, and we give Ammoderone or sotalol in this classification. Then we have class 2 drugs that we discussed in the previous slides, which is beta blockers. They act on these phase 4 level, and when we discuss about fourth classification about the calcium channel blocker, they act on these phase 2 period. So you have to see that, you can see in calcium channel blocker, the calcium is moving in, so they block the calcium channel, and in that case potassium is going out, and then they blocking these channels. So these all refractory periods are very important to understand the role of different drugs that act on different phases. What is meant by torsades D point? It is also responsible for abnormal cardiac rhythm, and that is responsible for sudden death. That point out that significant QT interval prolongation. So if the QT interval prolongs significantly, so the ECG will appear like this, and that is responsible for sudden cardiac death. So when we have class 3 drugs like Ammoderone, or we have Doronodorone, Sotalol, Dofetilide, or Ibutilide drugs, they belong to class 3 drugs. When we talk about Ammoderone, which is mostly used class 3 antiarrhythmic drugs, they are responsible for blocking the potassium channels. It has also blocked the calcium channels, sodium channels, and alpha beta receptors. But the problem is that it also responsible for prolongation of the action potential and especially QT interval. So obviously if the QT interval prolonged, then it could cause torsades D point, but the incidence of this torsades D point will be low in case of Ammoderone. They are also responsible for slowing heart rate and AV conduction as well. So the cardiac effect consists of prolongation of the action potential duration by a blockage of the IKR, or blockage of the potassium channels. IK will be also blocked during the chronic administration, because beside it also block the inactivated sodium channels, despite it belong to class 3. So another thing that is very important in Ammoderone, that either they are blocking the potassium, but they are also responsible for blocking the sodium despite they are present in class 3. So this is very important. The reason is still not yet known, that why they are blocking the sodium, as well as they are not belong to sodium channel blocker, but their main role is to block the potassium channel, but they are having the weak adrenergic and calcium channel blockage action. So their action is on calcium channel blocker, and adrenergic receptors blockers are little bit weak, and they are also responsible for slowing the heart rate and AV node conduction. The toxic effect consists of bradycardia. It can block heart block in diseased heart. It could lead to peripheral vasodilation. It could be responsible for pulmonary and hepatic toxicities, or hyper or hypothyroidism, and patient has halos in the peripheral visual field, so they can affect the visual functions. And the drug interaction could lead to drug interaction because of the cytochrome metabolism, and because of the metabolism it acts as separate for liver cytochrome 3A4 and inhibits cytochrome P450. So the inhibition of cytochrome P450 is responsible to potentially interact with number of drugs. So the therapeutic uses, the dose could be the 100 to 200 milligram per day for maintaining the normal sinuses rhythm and in patient with arterial fibrillation. It is also effective in prevention of recurrent ventricular tachycardia. So the clinical uses of this drug is for serious ventricular arrhythmias and supraventricular arrhythmias. When we discuss about the calcium channel blocking agents which belong to class 4, the drug is Verapamil and Diltiazem, and these drugs are responsible for blocking the calcium uptake, and they are known as non-dihydropyridine, which is also calcium channel blocker. It is used for the treatment of actually supraventricular tachycardia and used to slow the arterial fibrillation and arterial flutter. So what we know that there are different kind of channels like L channel or T type channels. So we know that L type channels found in both ventriculars and arterial cells. So blocked by the therapeutic level of calcium channel blockers such as Verapamil and Diltiazem, they can act on L type calcium channels and block them, or they can also block the T type channels which is present in sinoarterial node and arterioventricular nodes, but still no clinically approved yet. Is not, and the drugs are still under trial for T type calcium channel blockers. So we need to understand that the calcium channel blockers are of different type, like L type or T type, depending upon anatomical position. The L type channels are present in ventricular and arterial cells, whereas T type channels are present in SA node and arterioventricular nodes. So they are different drugs and they're working by blocking different type of calcium channels. So what the mechanism of action of these drugs, that these L-type calcium channel blockers slowing down the sino-arterial node and arterioventricular conduction, as if we see that they can responsible for slowing down, especially they are present in ventricular cells and arterial cells. So they can slow down the conduction, especially sino-arterial and arterioventricular nodes, and decrease the atomicity in sino-arterial node and AV node block, that is responsible for termination of supraventricular tachycardia. So they are responsible actually inhibition of the inward movement of calcium. As if we go back to the previous slide, like here they mention here that calcium channel blockers that working on phase 2, so the calcium uptake will be decreased from that section, so it could be effective in that way. So thank you so much for today's lecture. Hope to see you again.